Bismillahirrahmanirrahim. So today we will discuss the next topic. We have already discussed the CSF rhinorrhea, and so today we will carry on the same topic. We have discussed this, how the CSF rhinorrhea can present in the different diseases and the management of the CSF leak. So today we will discuss the foreign bodies in the nose. The patients who have got the foreign body in the nose, they are usually either the children or the mentally retarded adults. And all sorts of things which are present all around, they can, the patient can put them into the nose. So they can be the animate foreign bodies and they can be inanimate foreign bodies. So inanimate foreign bodies include either they are vegetable of the origin or non-vegetable in origin. So the common among the vegetable in origin are the peas, maize, grams, beets, nuts, and in the non-vegetable, the papers, cotton woods, pencil, erasers, chalks, the minerals, among the minerals, the plastic toys, the washers, pebbles, nails, metals, and among the animate foreign bodies, they are the maggots, leaves, and the insects. And the majority of these foreign bodies are inserted by the patients themselves, and the most common route is the anterior nares. The accidental insertion can be by either the vomiting or the coughing, the penetrating wounds, the penetrating injuries, or the nasal surgeries. The surgeon has left behind some piece of the gauze or the other piece in the nasal cavity, or it can be secondary to the palatal perforations. So the foreign body is entered from the oral cavity into the nose. And if these foreign bodies remain in the nose for a longer period of the time, then they can present with the complication including the rhinolith formation. What happens is, if the foreign body remains in the nose for the longer period of time, it will impair the normal drainage of the nasal cavities, and there will be stasis of the secretions. So if there is stasis of the secretions in the nasal cavity, as the nasal secretions are having the proteins among them, so they are very good culture medium, so they can induce the infection in the nasal cavities. And if it remains in the nasal cavity, it will start growing in the size because of the edema around. There will be inflammation, and the mucosa around will get inflamed. So ultimately leading to either to ulcer formation, or there may be the granulation formations as a result of the chronic inflammatory process. So if this foreign body remains for the much more longer period of the time, the nasal secretions, which includes the calcium and the magnesium salts, starts getting deposited on these secretions, and now the patient will develop the stone formation in the nose labeled as the rhinolith formation. Among the non-vegetable foreign bodies or non-animate foreign bodies, the one thing which is much more important is the battery cells. So if the patient put the small battery cells, which are quite common nowadays, used in the watches, etc., etc., if the patient gets the foreign body in the nose, as they are charged, so they have got electric charge, so they will cause the necrosis of it will produce the electric burns around the nasal wherever they is present. So it will lead to the necrosis, and the ultimately it can lead to the septal perforation. So how the patient presents if the patient has got the foreign body in the nose. So it can present if they are inanimate foreign bodies. Usually either the patient gives the history of the presence of the foreign body in the nose, and the patient can present with the nasal obstruction, can present if it remains for a longer period of time, so it gets infected, as a result there is hyperemia, and the patient can present with the blood-stained nasal discharge labeled as the serous ingress discharge. Or sometimes the patient can present with the mild epistaxis or the severe epistaxis as well. As the nasal cavity is now closed due to the presence of the foreign body, the patient cannot breathe, so the patient can have the hyposmia or cacosmia. Among the animate foreign bodies, it causes the irritation, more irritation than the non-animate foreign bodies. So the patient has got the formication. Formication means presence of the irritation in the nasal cavity and the marked inflammation. So the formication, in the formication, there will be more redness, there will be more irritation in the nasal cavity, and the patient will have as the reaction is more marked. So there is more pseudosanguous discharge in the nasal cavity, or the foul smelling discharge will be present in the nasal cavities. So the patient will present with the discharge from the nasal cavities. So we can see the presence of the foreign. If we look into the nasal cavity by either doing the anterior endoscopy or by doing the endoscopy, so we can see the foreign body's presence in the nose. In this picture we can see the leech. The leech is the foreign body which patient can present with bleeding from the nose. This leech is usually present in the people who take the bath in the mud areas. So the patient, or sometime the patient who drink the canal water, or the water from the ponds where the leech is present, they can ingest the foreign body, and that can get stuck into the nasopharynx or in the nasal cavity. So it gets stuck, as the leech is an organ which sucks the blood. So the patient will present with irritation and the blood stain discharge from the nasal cavity. Among the animate foreign bodies, metallic foreign bodies, inanimate foreign bodies, the metallic foreign body is quite common. These include the screws, or the rings, or the small beads. So these foreign bodies can be identified by either the anterior endoscopy or the endoscopy, or by doing the x-rays. Now we can look at by doing the x-ray of the lateral view of the nose, we can see the presence of the foreign body where it is present. So the diagnosis of the foreign body is made by looking into by taking the proper history, and by looking into the nasal cavity, either by doing the anterior endoscopy or by doing the nasal endoscopy. So how will the patient present? The patient will present either the obstruction of the nose, which will be unilateral, or the blood stain discharge from the nose. Or if the foreign bodies remain for the longer period of time, then the patient will have a foul smelling nasal discharge, or the cacosmia. So this foreign body can be seen by doing the anterior endoscopy. Sometimes if the foreign body remains for the longer period of the time, and it causes the chronic inflammation, so the granulation tissue formation on the foreign body may get. We cannot see the foreign body in the nasal cavity, but what we can see is the presence of the granulation tissue in the nose. And if we palpate the nasal cavity by doing the probing, we can feel that there's something which is present in the nose. So then we will do the x-rays. So if the foreign body is opaque, it will be shown, but if the foreign body is not totally opaque, it will not be shown on the x-rays. So the x-rays which we normally do is the x-ray of the paranasal sinuses, lateral view, or sometimes we do the occipital views as well. If the foreign body remains for the longer period of time, then we suspect that it is the ranolith, then we do the x-ray of the paranasal sinuses, or we can do the CT scans of the nose. So the treatment of the foreign body definitely has to be removed. So it will be removed either without anesthesia or with under general anesthesia. So depending upon whether the patient is cooperative or the patient is non-cooperative, or the presence of the foreign body is whether it is impacted or it is non-impacted. So what we take is we take the curved hook or the Eustachian catheter and pass it behind the foreign body and then pull it out. So if the patient is uncooperative, then we have to use the general anesthesia to remove the foreign body. Or similarly, if the patient is mentally retarded or the foreign body is impacted, we cannot remove it without anesthesia, as it will be very painful. Then we have to use the general anesthesia, and then we will remove the foreign body with the help of either the foreign body forceps or the foreign body hook, or by pulling with the Eustachian catheter. The leech, the animate foreign body among the leech is very difficult to be removed with the forceps because it gets stuck, it bites and gets attached to the nasal mucosa. So we will remove it by putting a pinch of salt. So if we put a pinch of salt or the hypertonic saline, or we touch with the collector with the cautery, then it will leave its bite and will come out very easily. Or what we can do is we can put a few drops of dilute acid which is the acetic oxalic acid, or we can put the acetic acid as well in the nasal cavity. So the among the animate foreign body, the other are the maggots. So the maggots are removed in the same way by putting the turpentine oil. The turpentine oil is very irritable oil, so it produces the irritation and causes the pain sensation on the maggots, because the maggots have got a very delicate mucosa on them. So it starts moving and will come out of the nasal cavity. So these forceps can be used to remove the foreign bodies, especially the cells or the animate foreign bodies. These forceps are labeled as Tilley's for nasal dressing forceps. So this is the Eustachian catheter, which I will already mention. So this hook, we will pull this Eustachian catheter behind this foreign body, and then we will pull it out. So this is, or we can do the Foley's catheter. We can put this catheter behind the nasal. We can bypass this foreign body by bypassing the Foley's catheter, and then we will inflate this balloon, and then we can pull it out. So among the foreign body is another variant is the rhinolith. So what is rhinolith? A rhinolith is the stone formation in the nose. So as already discussed, that if the foreign body remains in the nose for the longer period of time, what it will cause the chronic inflammation. So if there is chronic inflammation, it will result in the granulation tissue formation. There will be retention of the secretions, and as the secretion contain the magnesium and the calcium salts, so they start getting deposited on the foreign body, and ultimately resulting in the formation of the stone, which is labeled as the rhinolith. So this, if it is not removed, it will gradually increase in the size and will keep increasing in the size, will cause the complete obstruction of the nasal cavity. So it will cause the obstruction of the drainage of the sinuses. So the patient can present with the epistaxis, or there can necrosis of the septum, or the ulcer formation of the nasal. So how this patient presents, the rhinolith is usually seen in adults due to it usually presents in the adults. Why? Because the foreign bodies remains in the nasal cavity for a longer period of time. So even if it is child, it will take 1 year or 2 years or 3 years to develop into the stone formation. So the patient will present with blockage of the nose. They will nasal discharge. So this is how this rhinolith looks like. So we can appreciate the presence of the stone in the nasal cavity by if you do the endoscopy, and on X-rays again we can see a radio opaque shadow in the nasal cavity. Patient with the rhinolith presents with the unilateral nasal obstruction, foul-smelling the nasal discharge because of the retention of the secretions in the nasal cavity, and there is secondary epistaxis and the infect sinusitis. So the patient has got the unilateral blockage of the nose, the foul smelling discharge coming out of the nose, or the blood stain or serosanguinous discharge from the nose. Sometimes the patient presents with the mild epistaxis or the severe epistaxis and the neuralgia. And this neuralgia is due to the pressure on the nerve which is supplying either the septum or the lateral nasal wall. And what this nerve is, this is the trigeminal nerve which is supplying either the sphenopalatine or the anterethmoidal nerve which is supplying the nasal cavity. And the pressure on these nerves can cause the neuralgia, and the patient can present with the pain on the face or in the region of the orbit, or by just touching the face. So the patient can present with symptoms of the trigeminal neuralgia. So if we examine the nasal cavity, what we will see is grayish irregular mass which is present in the nasal cavity, which is brittle on touch. And so it is irregular mass, feels stony. If we touch it with a probe, it will feel brittle like and will break off if we try to remove with the probe. And it may start bleeding due to the presence of the inflammation around, and there's presence of the granulation tissue around the body. So as the nose is very vascular area, so if we touch the nose, so there's inflammation around, so it will start bleeding. So how we will remove it? We can do the CT scan of the nose. We can see the radiopaque shadow in the nasal cavity, and we will, if we remove it, there is a huge mass which is a stone which is present in the nasal cavity, and it is usually removed under general anesthesia. So the treatment is majority of these foreign bodies or the rhinolith is removed endoscopically, either under local anesthesia, but the rhinolith is usually removed under general anesthesia because it is very painful if we try to remove it. And sometimes we have to, if this is large one, just like this one, it is large, it cannot be removed without anesthesia, and we have to break it down to remove it. So we have to break it down and then remove it in piecemeals. And if the foreign body is quite large and it goes into the nose, from the nose it goes into the maxillosinus or into the ethmoids in this area, then we have to remove it by breaking it down or with the help of the endoscopes, using the telescopes, either the 0 degree or the 30 degree, or by doing the lateral rhinotomy. So what is lateral rhinotomy? Lateral rhinotomy is cutting the nose from the lateral side, opening the nasal cavity, and then removing the next type of foreign body is the presence of the maggots in the nose, which is labeled as the nasal myices. So how these myices are formed? They are the larva formation of the blue bottle flies. So what is the blue bottle flies? They are the common flies which we see all around. जो आम मक्खियाँ उन्हीं को कहते हैं blue bottle flies. So what happens is the patient is in habit of not keeping the nasal hygiene quite good. So the patient is practicing the bad hygienic practices. So what happens is this fly will sit on those nasal secretion and which hatch the eggs. So if it hatch the eggs, it will grow into the larva formation into 4 to 7 days, and then it gets converted into pupa formation in 10 to 20 days, and then egg is formed. So what we see in the nasal cavity is this larva formation, and it is labeled as the maggots. This is attracted. This fly is attracted due to the foul smelling, due to the presence of the nasal secretions, and these nasal secretions we see in atrophic rhinitis, or in case patients suffering from the syphilis, the patient suffering from leprosy, or the prurulent sinusitis, or the patient who got the radiation therapy post radiation therapy. So the nasal secretions in these patients gets stuck up and there's an inflammation. So this, as a normal flow of the secretions is impaired. So the retention of the secretions leading to the sinusitis, this fly will hatch on the eggs on it, and resulting in it will give the eggs, and this will in 4 to 7 days it will form the larva, and the patient will present with the larva in the nose. And what this larva causes is it is animate and has it will cause the destruction in the nose because it start eating up the secretion in the nose, and secondly then it will invade the necrotic tissue. It will eat the necrotic tissue, and along with the presence of the foreign body or the maggots, it will cause the inflammation around it and will cause the severe inflammation. So the patient has got the swelling on the face or in the palate or the cellulitis around the eyeball. And when we see these cases, we normally see these cases when the flies are more. So these months are usually the rainy seasons. So this is the how the maggots are present in the nasal cavity, and it will develop into the flies. So the clinical features, how the patient will present is, the patient will present with severe nasal irritation, and there will be sneezing, there will be lacrimation due to the presence of the irritation in the nose, and there will be headache, and as the presence of the foreign body, that is the number of maggots, will cause the obstruction in the nasal cavity, either due to the presence or the presence of this secondary to the sinusitis, which is already present there. So as these maggots start eating, so they will cause the slight epistaxis, and the patient will present with the blood-stained discharge or labeled as the serosanguine discharge. As the maggots are the living things, so it starts eating the normal mucosa. So the patient will have the swelling around the nose, will have the puffy eyelids, they will swelling around the lips or the facial pains and the swelling on the face. Or the patient can have the presence of the feeling of the crawling sensation. The crawling sensation means that as these maggots will move, so the patient will have the crawling sensation, and then its presence of the irritation in the nose, and this crawling sensation is labeled as formication. And sometimes if the maggots are more, they will start dropping down from the nasal cavity, or the patient will present with that the something is coming, some sort of insects are coming out of the nose. So if the patient is neglected or does not report early, so this will eat the nasal cavity and will present with the fistula formation. What is fistula? Fistula is presence of the communication between the two epithelial surface. So this fistula can be from the nasal cavity onto the face, labeled as cutaneonasal fistula, or can be from the nose into the palate, labeled as oronasal fistulas. So if the fistula is present, the maggots will start crawling out from the fistulas, and the patient can have or there will be difficulty if it is oronasal fistula. What will happen is, when the patient will swallow, the fluid will come from the nasal cavity, and if it is not treated, as the nasal cavity is surrounded by the bone, we go back and see that this nasal cavity is surrounded by the orbit. So these maggots can go into the orbit, can go into the ethmoid, can go into the orbit, and if it goes into the orbit, the patient will develop the orbital cellulitis and can develop all the complications of orbital cellulitis. So the nasal cavity is present at the base of the skull. So if it eats this bone from the ethmoids, it can go up into the nasal. So this is the cribriform plate. So it can, and this is the fovea ethmoidalis. So it can break this bone and can go into the nasal, into the brain, and now the patient will develop what will happen? The patient will develop the meningitis. the patient may develop the meningitis. So the treatment of this is the endoscopic removal of the maggots. The treatment is endoscopic removal of the maggots. We can do what we advise is they irrigate the nose with the dilute chloroform or the turpentine oil. The chloroform, what the chloroform will do, dilute chloroform. So this comes as in the market as labeled as the maggot oil. It contains the chloroform, which is in diluted form. It will anesthetize those maggots, and the turpentine oil will cause irritation on the nose, and the maggots will start dropping down from the nasal cavity. And after that, after putting the maggot oil, we ask the patient to take the nasal douches with the normal saline. So these maggots the dead maggots and the live maggots will start coming out of the nose. The crusts are also removed by doing the nasal douches, and the slough will also be removed by doing the nasal douches at the regular intervals. As the normal secretions are, the nasal cavity is injured, so it will result in the bleeding, and there will be crust formation, the scab formation. So these scabs needs to be removed at regular interval, and we ask the patient to put the liquid paraffin or the lubricant in the nasal cavity so the crusts does not form. And we also ask the patient to use the mosquito nets to avoid the flies during that period. And to prevent the secondary infection, we have to put the patients on antibiotics and the analgesics, and ask the patient to keep the nasal hygiene quite good. So the last topic among this is the corneal atresia. What is the corneal atresia? Atresia means complete absence or the complete blockage of the nasal cavity. So this guano is labeled as the posterior nares, is also labeled as the guano. We know that the nasal cavity is developed from the nasal palacords. This nasal palacord is developed from the foregut. So the nasal palacord develops, and then this nasal palacord gives rise to nasal pit formation. So nasal pit formation, and so then this nasal pit communicates the nasal cavity with the buccal cavity by the guano. So if there is failure of this cavitation and there is persistence of the membrane, that is the buccal membrane, which is present posteriorly, so it will cause the obstruction, the lack of communication between the nasal cavities, and so the persistence of the nasal cavities, and so it will result in the non-formation of the complete canalization of the nasal cavity. So there are other theories as well, that it is secondary to the medial outgrowth of the palatine processes, or the abnormal mesodermal adhesion in the posterior guana. And this we also see in the patients who use the antithyroid medication, especially carbamazepine during the first trimester. If the lady is hyperthyroid and is using the carbamazepine, then these patients may develop the corneal atresia, which may be unilateral, it may be bilateral. So this is how this is a pit is formed secondary to this is the foregut. During around 6 weeks during the intrauterine life, this nasal pit deepens down and will communicate with the foregut posteriorly. So this area is the nasopharynx. The nasal cavity will open into the nasopharynx. So if complete canalization does not occur, then it is labeled as the atretic plate is present, and we label it as corneal atresia. So this is the normal process, and if it remains, so this normally canalization occurs, and this area is called the guana. So this canalization occurs. So if the complete canalization does not occur, so there is atretic plate present here, and we label it as the corneal atresia. So this can be unilateral and it can be bilateral. unilateral is more common as compared to the bilateral. And again, it can be bony, it can be membranous, or it can be combination of it. So it can be associated with the charge. What is charge? Charge is the chloboma, the atresia of the cornea, the genitourinary abnormalities, the heart defects, retarded growth, and the ear defects. So the unilateral corneal atresia usually presents late, and they usually presents late due to the difficulty in feeding, especially these children take breath from as they are they depend upon the mother feed, so they usually take the feed from one side, from one breath, because if the mother uses the second breast to feed the baby, it will the one which is on uppermost is closed, so the patient cannot take the breath. So these patient will have got has got the difficulty. The mother can present that this baby is not taking the proper feed, or they is malnourished. So, or if the mother is intelligent enough, then he can pick up that is blockage of the nose, or the presence of the nasal secretions coming out from that side. While the bilateral corneal atresia, that has to be diagnosed by the medical professionals, especially those who are present at the time of the birth. It is not diagnosed. Usually, it is not diagnosed by the ENT person. It has to be diagnosed by the person, either the gynecologist or the nurse. He has to be, or she has to be intelligent enough to identify that there is some abnormality presence in taking the breath. So what happens is, as the children are not the newborn baby is not the natural oral breather, it is the natural nasal breather. And how it presents? It presents that when we close do the suction of the oral cavity, the patient is breathing normally, and then as he closes the mouth, so the patient develops the cyanosis. So whenever he closes the mouth, the patient will develop the cyanosis, and this cyanosis disappears if he starts crying or open the mouth, and there will be difficulty in taking the food, and so it has to be diagnosed by the person who is looking around that baby at that time. So in case of the unilateral corneal atresia, the patient will have the unilateral nasal discharge, and if we try to pass the feeding tube from the nasal cavity into the oral cavity, there will be failure to pass this tube. Or if we do the cold spatula test, that is, we put the spatula around the nose and try to see the fogging on that spatula, and then there will be absence of the fogging. Or we can do the wisp test, that is, we put a small wisp of the cotton around the nasal cavity, and we can check that one nostril is closed. While the bilateral corneal atresia presents with the repeated episodes of the cyanosis. The ENT surgeon or the ENT person will do the endoscopy of the nasal cavity with small endoscope, and can see the plate behind. Or if we try to put the flexible endoscope, we can again see that it will failure to pass that scope. The rhinogram is, we can put the dye in the nose and then put the patient on the head down position. That dye normally should go from the nasal cavity into the oral cavity, but there will be failure to pass that dye from one side. Or we can do the CT scan, and we can see the thick plates present behind. So this is how it will look like. There is no patency. This is the posterior corner. There is no patency. We can see there is no patency behind. It is closed from behind. So this is normal, and this one is closed. And what we do is we have to put the airway immediately to save that. If we don't put the airway, that is the oropharyngeal airway, the patient will die. What we see, this is the rhinogram. We put the dye in the nasal cavity. It should normally go from the nasal cavity into the nasopharynx. But what we can see here is that the dye is present in the nasal cavity, and it has not gone into the nasopharynx. So this is the CT scan. We can appreciate the thick bony plate present behind. This is the axial view, and this is the unilateral corneal atresia, and this one is the bilateral corneal atresia. So the treatment emergency is we have to put either do the intubation or put in the oropharyngeal airway, and immediately we have to do either the intubation or we have to do the tracheostomy. And for the feeding, we use the Maggots feeding nipple, which has got a large hole which we put in the oral cavity, and from this feeding nipple has got the 3 holes. Once in the center for which is used for the feeding, then from the sides the patient will be taking the breath at the same time. And the definite treatment is the removal of that atretic plate, which can be done either with the endoscope, that is transnasally. If it is membranous, which can just be punctured. If it's a thin bony plate, again it can be punctured. While if it is thick, that needs to be drilled out. And the second approach is the transpalatal approach. We open from the palate and remove this plate, and then do in the same way as the cleft palate surgery is done. Open from here and drill this plate, and then close from below. Okay. So this is how we can approach we can close the nasal cavity. We have to put the nasal tube, because anything which is circular, if we close it, it will close by itself. So we have to put a tube in for at least for 6 weeks to 12 weeks, so till the healing is complete. We will put the tube from the nasal cavity. It will reach up to the oral cavity, and it will remain for at least for 6 to 8 weeks. So we have to tie it bilateral, okay, and we will stitch it in front, and this is how it is done. Thanks.